Well, thank you everybody for joining us for these updates in upper tract urothelial cancer, where we talk about challenges in diagnosis and treatment. So just so everybody's oriented, we're talking about cancer of the renal, pelvis, and ureter. You can see this in the drawing and what is in the red. And collectively, we consider these upper tract urothelial carcinoma, or UTUC. These are fairly uncommon cancers, or we could consider them rare, incidence of about 2 per 100,000 in Western countries. There is, of course, a strong association with bladder cancer or lower urothelial carcinoma. We do see these two cancers occurring concurrently in about 17% of cases. Patients who have initial upper tract cancer can develop recurrence in the bladder 22 to upwards of 50% of the time. And conversely, patients who have bladder cancer can develop upper tract cancer less commonly, but it certainly is seen 2 to 4% of the time. And one thing that is a bit more unique and different about upper tract compared to bladder is that it's much more likely to present as invasive disease, although as you will hear, and some of you may know, this is difficult to identify ahead of time. Now, upper tract and bladder urothelial cancers for a long time were considered to be the same disease. And of course, under the microscope, phenotypically, they're very similar. But there are practical, clinical, and genomic differences that we're learning about. At a purely practical level, there are very few randomized studies done for this more uncommon disease. There's a total of 5, and really 4 of these have only been in the past 5 years. Interestingly, we also see many more women diagnosed with upper tract disease as compared to bladder cancer in regard to the ratios. So much less predominance of men, let's say. And also, toxins seem to play an important role for upper tract disease, particularly aristolochic acid toxicity and also arsenic exposure. Lynch syndrome is associated with upper tract urothelial carcinoma much more so than in bladder cancer. And in regard to staging, while it's still not perfect for bladder, we have high reliability of transurethral resection, exam under anesthesia, and imaging to be able to provide some reliable guidance in terms of staging, but yet we really don't have that as well for upper tract by any means, and it's highly imprecise. And so therefore, what we've been really talking about lately is risk stratification. Intracavitary therapy is a big part of treating bladder cancer. Of course, the bladder is a reservoir. It lends itself to be easily accessible and for us to put solutions in there that can treat it. And yet with upper tract disease, we have anatomical barriers. It is not a reservoir. That whole anatomy is made to propulse fluid down to the bladder, and it's difficult to access compared to the bladder. Lymph node dissection, something that is well established for bladder cancer, and yet this is something that we're still learning about for upper tract disease. And then more recently, what we're learning is that even though we see the same types of mutations for these two cancers, their distributions are somewhat different. So bladder is highly driven by P53 and RB1 mutations, whereas FGFR3 alterations play a minor role. On the other hand, for upper tract disease, we see FGFR3 alterations playing a dominant role, P53 less than what we see with bladder, and RB1 is actually quite rare. Now, tobacco is linked with both cancers. It increases the risk for both and is one of the strongest causative factors that we know. And this plays a role through aromatic amines and detoxification pathways. And of course, there's also occupational exposures, particularly petrochemical. As I mentioned, aristolochic acid nephropathy within the past 8 to 10 years has been recognized as being the causative factor of Balkan endemic nephropathy, as well as Chinese herbal nephropathy. And this not only is associated with upper tract disease, but also significant renal dysfunction. And there are major public health efforts in the Balkans and in Taiwan, so the rates of this do seem to be improving. Also, arsenic exposure, particularly in well water in rural areas or areas such as in Chile, where there's very well documented areas of exposure and then likewise disease development, and also in Camp Lejeune during a period of time in the late 50s and early 60s. What's interesting also about upper tract disease and somewhat different than bladder is its association with Lynch syndrome, something that we are recognizing more and more. This is a study from the French group that looked at the database of their nephroureterectomy specimens and also looked at the patient's family history, personal history of cancers, as well as age of onset. And based on these factors, determined that about 21.3% of these patients were at risk for having been misclassified as having sporadic disease, whereas they could have had an inheritable syndrome. Now, there was no validation of this based on any germline studies or genetic studies that were done, but it does bring attention to this fact. And this is something that we were actually interested in many years ago, and as a multidisciplinary effort, decided that we would screen all our upper tract patients as they're coming into clinic. We do this just with basic Amsterdam 2 clinical criteria, and whenever there's tissue available, we do standard of care tissue testing, which is already available. And when we went back and looked at our data, we found that about 5.2% of upper tract patients have an undiagnosed Lynch syndrome, which is an inheritable syndrome, which has implications for these patients' family members as well. But there could be upwards of about 13.9% of possible inheritable mutations. And this is possible and not definite because these patients, for one reason or another, did not have confirmatory germline analysis. Now, as it turns out, since then, we are now offering essentially free of charge germline testing for all our upper tract patients. And so we will see how that bears out over time. And then much more recent data, which is quite interesting for upper tract disease, looks at the particular molecular subtype of these, finding that the majority are luminal papillary, again, somewhat different than bladder, which tends to be more basal. And this is a study by Robinson et al. From Bischoy-Faltus's lab, which we were honored to collaborate with. Basically, they compared TCGA as well as the MD Anderson upper tract database, as well as the UNC, and we're able to do this hierarchical clustering, finding that the majority of these cases are luminal papillary, but also are highly T-cell depleted, suggesting that they are not really responsive to immunotherapy. And in addition to this, with a high rate of FGFR3 alterations, more than twice as high than what we see in the bladder. And so in terms of more practical considerations for day-to-day practice, we rely on imaging and ureteroscopy for staging and grading, but we also recognize that these have limitations. Imaging is important. On a CT urogram, we can look for filling defects and what their size are, how many there are, if there's infiltration, lymph node enlargement, the status of the contralateral kidney, and usually we want chest imaging to make sure that there's no metastases and also to provide baseline study for future surveillance. We perform cystoscopy to clear the bladder, maybe if it's a distal ureter tumor at the time, assess the bladder capacity for a psoas hitch or Boari flap if that's relevant. But many of us do rely on ureteroscopy as a backbone procedure because it helps assess the tumor size better than CT. It provides information on the tumor architecture, which is an independent predictor of outcomes, multifocality, which may not be evident on CT, and then we can do a biopsy. And the biopsy will tell us if it's low grade or high grade with some reasonable reliability, although there are concerns about low grade tumors potentially being upgraded, particularly if adequate sampling is not performed. But there are limitations to this staging. Imaging may not show infiltration or clinical T3 disease, such as this example that I have here in these figures. The biopsies that we do are superficial. They're essentially mucosal biopsies. They don't go deep enough to tell us about invasion. And so diagnosing muscle invasive upper tract urothelial cancer is not really in our lexicon. It's not a realistic lexicon of dialogue that we can have, whereas that's how normally we talk about bladder cancer. So we have to keep in mind some of these practical differences. Now, in these cases, radical nephroureterectomy can be highly curative, but the problem is that it comes at a cost of significant loss of kidney function. Particularly in this population, there's a very high rate of pre-existent kidney disease, And when patients undergo nephroureterectomy, the overwhelming majority are left with some degree of kidney dysfunction. And this can have implications not just for systemic therapy if they have high-risk disease, but also its association with worsening heart disease, for example, and lower survival. Now, particularly when we're talking about low-grade, low-volume disease, more and more this is considered overtreatment. And what we end up doing is recommending kidney-preserving treatments. However, then we're faced with the fact that there's high recurrence rates. In the upper tract, this can be upwards of 90% of the time. They can get recurrences in their bladder, and patients are exposed to multiple procedures and anesthetics, even though it may just be endoscopy. And so many of us have looked at adjuvant topical therapy as a way to try to reduce recurrences after endoscopic management, or in the rare case when it's just a pure upper tract carcinoma in situ, to try to treat this, for example, with BCG. But until recently, really, there has not been any prospective data. All of these studies are single institution, retrospective, and with a variety of agents that have been used, and with a variety of different delivery mechanisms, such as shown here, whether by nephrostomy tube and a slow drip, or by placing a ureteral catheter cystoscopically and delivering it that way, also through a slow drip. So next, we're going to hear more about some of the promising developments for this disease.